Okay, ladies and gents, are we reaching a point where we're ready to go? This might feel a bit like overkill with me using a microphone, but it's really for recording purposes, and I'll say a bit more about that in a second. Just to say, I think normally on occasions like this, somebody stands at the front and welcomes you to the town, but you live here and I don't. So I'll skip the kind of welcome, but just thank you for coming out today. My name's Andy Mills. I'm an independent chair, so I do work like this across the country. I work for an organisation called the Consultation Institute, and it works with local authorities, NHS bodies, utility companies, anybody who talks to the people who use their services, and helps them understand the best way to get that voice heard in their decision-making processes. So the success regime has asked for somebody like my organisation, our organisation, to come and be part of it, to make sure that the consultation process, which is what we're now in and why we're here today, is run in a fair and transparent way. So my role today is to help you get answers to any questions that you've got, and to help the panel, they'll introduce themselves in a second, give an opportunity to talk to you about some of the ideas in a bit more detail that's contained in the consultation document. Brilliant job for some of you picking it up and brandishing it and hopefully taking it away today. We'll say a bit more about how to do that, but obviously this is a process that you need to take part in, and there's various ways in which you can do that. Filling in a paper copy is one of them, and that's why we've got some at the back, but you'll be aware there's also a website, and when John gives his presentation in a second, the web address will be up, and I'll be interested to see how many people have kind of accessed any of that information that's on that website. So just a little bit of housekeeping. I haven't checked actually about a fire alarm, but I assume in a public building, when the fire alarm goes off, we'll know about it. There's plenty of ways to exit the building, and I would assume our muster point will be on the car park out here. Is that right? The lady's nodding. Are you happy with that? Toilets are just through the access point at the back. Final point about kind of mobile phones and iPads and all kinds of other bits and bobs. If you've got all of those, if you could just put them onto silent, that I think might help everybody. Okay, so can I ask the panel to introduce themselves? And then I think one of the panels is going to take you through a short presentation, and then I'll chair a question and answer session from you. So if I could hand over to the panel, would you like to start with yourself?
Hello, my name is Joanna Cox. I work for North Cumbria University Hospitals, the Acute Trust. I work solely at Whitehaven. I work in acute medicine and elderly care medicine.
Hi, good afternoon. My name's Rick Shaw. I'm Service Development Manager for North West Ambulance. I've got a history of operational management, so I've looked after Morecambe Bay, Millom and North Cumbria as well, so I'm very aware of the challenges and issues that we face.
Helen, do you want to?
Hi, I'm Helen Ray. I'm the Chief Operating Officer at North Cumbria University Hospitals.
I'm John Howarth. I'm Deputy Chief Executive of the Cumbria Partnership Foundation Trust. I'm a GP, and you might see me on Fridays working in Millom sometimes.
Okay, John, I think you're going to take us through a presentation, aren't you? Just before you do that, I did say that it does feel a bit like overkill that I've got a microphone, but we're using it to record. So if people have a question to ask, we would like you to use the microphone because it gets picked up and we can make a recording that is for us to broadcast so that anybody who couldn't make the event today can access the information. If you prefer not to say who you are, or indeed if you represent somebody, we'd obviously like to hear who you represent, but you prefer not to say that either, that's your right not to do that. But as I say, we would like, if possible, for you to agree to record what you're asking. Is everybody broadly in agreement with that? If we get to a point where we're disagreeing, we can find a different solution. Okay, thanks very much. John?
Thanks very much. It's really great. I think I know almost everybody, not everybody, but I know probably 80 or 90% of the people in the room here, which is really good. And as most people know, we have a Millom Alliance, and we have a joint leadership group for the town now, looking at health services, and have worked with various groups, the League of Friends, a Millom Action Group, and so on. So I work for the Partnership Trust, so we run all the services outside the hospital, apart from general practice. But we are partners in the general practice with Morecambe Bay now, actually here in Millom, which is the first time in the UK that sort of model's been developed. So my task is to take you through where we're at with the success regime. So the success regime is what we used to call North Cumbria, West, North and East Cumbria. And it's now entered a different phase. It's in the consultation phase. Now, what that means is that we've entered a 12-week period of formal public consultation. So it's referenced in public law. It's a very formal legal process that's going on now. So the health leaders in the system and the different partners in the system want to make significant changes to pathways, for example, around maternity or beds, or there is a legal obligation to consult, and that's where we're in at the moment. This phase goes on till about mid-December. So these next few weeks are the opportunity for the public to formally feedback and influence this process in a much more formal way than has happened. At the back of this document, so the consultation document sets out the changes that are being consulted on. And at the back of the document is a feedback form, and there's all sorts of ways of feeding back. There's a website as well, and so between now and mid-December's consultation period, then the senior leaders in the success regime bringing in an independent group to formally and independently assess and analyse all the feedback. There's likely to be thousands of sets of feedback, particularly from West Cumbria, where a lot of these issues are quite contentious. So, and then taking into account the feedback, there will be decisions made in the spring, so probably towards March or so. I think I've got the time frames right for that. So I'm going to just very quickly take you through what's in the document and to explain it, and then I think the issues here, we've been here before. I think we know Millom very, very well, and so a lot of the pathway issues like maternity are going to be the issues that we need to spend time discussing here. Everyone knows the challenges. The challenges May 2014 it was the march in the streets here. The challenges of the NHS came to a head 2 years sooner in Millom, and but the challenges are, the rest of the system is catching up with recruitment issues, major recruitment issues, real issues around general practice recruitment, nurse recruitment across our community hospitals. In August, it was 39%, I think, the qualified nurse vacancy rates. We're filling them in with bank and agency staff, but really very challenging. General practice in Copeland, 1 in 4 of all the GP posts are vacant at the moment in Copeland, and that's getting more challenging because a lot of GPs like myself are getting old now, and so there's this bulge of over 50s GPs will be coming to retirement in the next 5 years. So it's a real challenge for us. We've got too many people going to hospital, and if you remember the work we did together with the Action Group and others as part of the Millom Alliance, we worked out that in Millom, in a year, 22,900 people left the town every year, mainly to Furness, but quite a few going to West Cumberland as well, and 17,600 outpatient appointments, for example. So what we're trying to do is bring a lot more care back. But there's too many admissions. Admissions in North Cumbria has gone up 20% in the last 2 years. Massive pressure in the acute hospitals. So colleagues like Joanne here are working really flat out to try and cope with the demand. The system in North Cumbria is about £70 million overspent on an annual basis. And across the Morecambe Bay, of course, this is foot in both camps, really. Perhaps more of a foot in the Morecambe Bay camp. It's very similar financial picture. So real challenges in the NHS for the funding. And it's not all this, but there is no recognition in the distribution of money around the NHS for rurality. So we get in Cumbria the same money that we would get if we had a population over 20 square miles, and we're 2,000 square miles with multiple sites. There's no and we've had quality issues. But there's also really good quality going on in a lot of a lot of the services. Really outstanding quality. So the success regime brought a lot of services in. It didn't bring the Millom Hospital, just for clarity, is part of Better Care Together. It's part of the Morecambe Bay discussions. So the community hospital in Millom was not part of the discussions in the success regime. But many of the pathways, like I'll go on to explain some of the children's pathways and maternity pathways, do impact on people here in South Copeland. One of the worst things we have, and we've had this a lot over the last few years, is we've been in limbo with a lot of different things, and one of the things about this is we've got to get through this phase and start rebuilding some of the healthcare services in North Cumbria, because we can't keep going around reviews and challenges and so on. We've got to start focusing on some of the delivery. We have spoken with the community group here at quite a number of national conferences as people come and visited Millom from all around the country now. Health ministers come to visit. We've had 2 health ministers of health come to visit. We've had people from South Africa come and visit us. And this vision for healthcare in North Cumbria of a remote and rural healthcare becoming exemplars for that, we're actually beginning to play that out in Millom in the way we're working together and working in partnership. All health and care partners working in very close partnership. We call the Millom Alliance. But we want to have that. That's our vision for the health service across North Cumbria. I'm going to skip a couple of these because we've done so much here. The whole integrated care community concept is actually, this is a place we're delivering this in the whole of Cumbria, really, more than anywhere else. It's the community following that march, and when we join together and join forces, we are moving much faster than anywhere else in the whole of the county in terms of delivering all the things we need to deliver. We're stabilising the general practice, shifting massive amount of care. So 23%, we worked out that the population of Millom, those 22,900 miles equated to 900 journeys out of town for appointments, equated to 1 million miles of travel. And with the partnership working we've been doing, we've cut that by 130,000 so far, fewer miles travelled. 23% reduction in emergency admissions from Millom. 10% reduction in admissions from care homes, all these things that we want to do as a wider system we're doing. So integrated care communities are what we've been doing here. They're the place-based approach, trying to deliver far more services locally, stop the travel and movement for healthcare. And that concept is a platform, a core platform for how we're building the health system, both across the Morecambe Bay. This is the building block for Morecambe Bay healthcare, and in the north of the county. So these are some of the. I'll just explain the very, very quick, high-level summary of what's being proposed. So these are the changes that are in the consultation document. But the most important bit of it all really is what I just skipped over then, which is this local place-based partnership working with the community and health and care to deliver much more care locally. So changes. So we'll start with children's services. There was a process in the success regime. There was a whole load of work streams and workshops and meetings where people, service users, general public, county council, a lot of the health providers began to look at the different options for delivery of children's services. And then we created long lists and then short lists. Now, the options that are in the proposal are three, really. One is the first is to keep children's inpatients, so children's ward at Cumberland Infirmary in West Cumberland, but actually selecting for West Cumberland Hospital some of the lower risk children, so the very, very sick children being moved to Carlisle, where you might have a broader range of specialists, children's specialists looking after them. Second option was to have inpatients at Cumberland Infirmary, CIC is Cumberland Infirmary, WSH, West Cumberland Hospital, and just see it like an assessment unit at Whitehaven, assess, and if you needed to be admitted, you'd move to Carlisle. And the third is no services at all at Whitehaven, and everything moving. If you've got sick children, you move to Carlisle. Now, in this document, there's a setting out the options, and then there's a preferred option. There's what, after doing the work, the health leaders in the system think is a preferred option. And this consultation process is about the health leaders in the system meeting and gathering the opinions and views of the experts of their own towns and communities and so on. And I think we need to make sure within the success regime that these are equally valued views of what people think. But it's option one. So the preferred option is to try and keep some inpatient unit at Whitehaven, but to be sensible and safe about it and not have a very, very, very sick children treated at West Cumberland Hospital. So children perhaps who are already beginning to recover but need more time and so on. Already, a lot of the very sick children are transferred to Newcastle and places anyway. So that's children's services. For Millom, most of people going for children's admissions go down to Furness General, but some do go up to West Cumberland Hospital. Maternity services, which is probably the most contentious of the different changes. Again, going through a series of options to have consultant-led maternity care at Whitehaven and Carlisle, midwife-led unit at Carlisle, so no consultants for getting involved in deliveries. Midwife-led unit only at West Cumberland Hospital, and then all deliveries being moved to Carlisle. So those were the things that were considered. And the preferred option that's being suggested, which is probably causing most of the disagreement in the consultation so far, I think, is that as a midwife-led unit at West Cumberland Hospital. What that would mean practically for Millom and this area of South Copeland is that at the moment so for most other things, most people move down to Furness General for care. At the moment, about 60% when we did our analysis for children's deliveries went up to Whitehaven. About 40% went down to Barrow. So you're in that sort of watershed area where you could perhaps choose to do either from Millom. But if there was a proposal for midwife-led unit for consultant-led care, so anybody who wasn't super low risk or selected out to be low risk would need to either go to Carlisle, which is a very long way from here, of course, or down to Barrow. So that was the preferred option. And probably the one that's most evenly balanced in terms of opinion, and lots of people on both sides of this, but that was a preferred option put forward in the consultation. Community hospital inpatient beds, I'm going to skip over this because it doesn't impact on Millom, but it was a consolidation of beds onto fewer sites around West Cumbria, with no beds at Alston, Wigton and Maryport, but continuing the beds in the 6 other units. We're working with the communities like Maryport. We've created a Maryport Alliance, we've created an Alston Alliance, and we've created a Wigton Alliance to try and work with the groups in these communities like we did, modelled on what we did here, to try and get to a really good joined up solution to try and find a way forward for these places. Emergency care, again, the options. So really important to say that outpatients will still exist. Older people's care, elderly care, still existing at both Whitehaven and Carlisle. There's various options looked at, but in a nutshell, option one is quite a very strongly preferred option to keep 24/7 A&E at Whitehaven. Most people would think, I've worked here for 30 odd years, for most people that makes enormous common sense with Sellafield sitting there and so on and so forth. Now, to get there, there is quite a new model of staffing being worked through at Whitehaven. The big difficulty is recruiting middle and junior grade doctors, and consultant grade doctors as well. But the modelling I think there'll be a lot more very, very talented, experienced nurse practitioners trained up to do higher level care, and possibly a new group called Physicians Associates, which are a bit like nurse practitioners trained in the medical model. But that's the way you've got to think to begin to. There's no point in putting that up and then not being able to deliver it. So there's quite a lot of work already started to make sure that that's sustainable. So 24. The preferred option is to keep A&E at West Cumberland Hospital. Stroke, hyperacute stroke is a bit of technical jargon. That means when you first have your stroke. So if you have a stroke, it used to be that we'd admit somebody to hospital, and then there'd be it would really be about rehabilitation and supporting people in the recovery. Now there are clot-busting drugs available. So the things that we used to do we still do sometimes for heart attacks where you inject, you can do that for certain strokes. There's a lot of evidence around the country that those are things that are best concentrated in very specialist units, because it needs quite a lot of skills. You need very quick access to. You've got to have a scan first to make sure you haven't had a bleed and so on. So the proposal for this is to concentrate that at Carlisle. So what that would mean, now most people with strokes here actually go down to Furness General and they work with, and now some might go up to West Cumberland. So if the further you are, so Millom and towards the Barrow end, it impacts less on this. If you go further up into South Copeland, into Ravenglass sort of area, going further, Eskdale, that sort of area, then you're really quite on a watershed. It's a long way to Carlisle, and it's a long way. But the evidence is for this. There's quite clear evidence around the country that unless you do put all the skills and it's about things like having a very quick access to the scans all the time, 24/7, and to build that at multiple units is quite difficult with the constraints that we have at the moment. So that's a proposal for hyperacute stroke. Now that doesn't mean all rehabilitation and so on. A lot of that goes on in our community hospitals and at home. But so it's the immediate treatment of stroke services. Now that actually poses challenges for us here in places like South Copeland and Millom, and in that we need to, if we sit on people with strokes, how many hours have we got for the thrombolysis, Joe? Is it 4?
It's 4, yeah.
About 4 hours. So there's like strokes and emergency. So there might be something we need to do in terms of around the COOM and so on, about making sure people don't sit on the symptoms. There's a thing called FAST, which is face, drooping of the face, weakness of your arm, speech, slurring of your speech, and then T is time to dial 999. And have you already done it?
We're actually working with MS at the moment to do a lifesaver page every month from next month it starts.
Fantastic. In our Newtown newspaper called Around the Coombe, which is one of the best, you might want to have a look at it. It's one of the best things you'll ever see, although I'm a bit biased. But what we need to do is for people, there's like a 4-hour window to get the clot-busting drug, and you've got to have had a scan in that process as well. So it doesn't give a lot of time for ambulance recognising something's going wrong, ambulance response. So the real message is you bypass everybody else, bypass people like me in general practice. You ring 999 if you've got these symptoms, and then you go to the right unit that's got the clot busting drugs. Because if we sit and wait on it, so we're going to have to, depending on how these changes emerge, we're going to have to get the right knowledge out to people, and we're uniquely placed here to do that, about how best to use the services if they are reconfigured, and how best, most safely to use them, and for what things that we might want to, this is, I think this is the last but one slide. This is just to leave people profoundly depressed at the end. This is our money, and I think the point of this slide is that the changes in here, people say, oh, they're about the money, and they are about money. I think we've got to, it's disingenuous to say all the discussions haven't looked at money. Of course they have, because we're £70 million overspending every year, and that's we're one of the worst overspending areas of the NHS in North Cumbria. Most of the savings, and we've done huge amounts of work to bring that gap down to nothing, or down to a very small amount in 5 years. Most of the savings don't come from these pathway changes. They come from other efficiencies, much more partnership working. And these overall changes, so were not driven primarily by money. They were driven primarily, I think the staffing issue drove a lot of the discussions, particularly around maternity, and real massive problems of recruiting paediatricians in particular, because you have to have maternity and all the services and anaesthetics, paediatrics around it, and the quality and safety for some of the things like stroke services and trying to get it right. So we have to, but it does impact. The further you are away from these centres, if you centralise anything, the further away you are from it, the more impactful these things get. And so I think that's. So West Cumberland Hospital. It's a fantastic building. We've got a new medical school. I don't know whether people have clocked this. We've now got our own medical school. I'm the professor of general practice in primary care in it. Been meeting this morning about how we develop it as a centre of excellence for rural and remote healthcare. And we've had links with Newfoundland, discussing with the medical school over there. Really exciting stuff emerging. But for West Cumberland Hospital, some of the acute surgeries, so there's been changes over the last 2 or 3 years, so there's lots of trauma moved off to Whitehaven, and some surgeries. So quite a bit of this, the leaders in the acute, colleagues in the acute trust, are actively trying to move as much as they can back to West Cumberland Hospital. It's got a brand new building. We need to use it, and I think it's about 50% of. There's a lot of people move to Carlisle for other things. It might just be for an outpatient appointment or something like that. They're trying to bring at least half of the movement that goes up to Carlisle back to West Cumberland Hospital. So that means more routine operations, some of the more minor trauma. You've got to get the balance right between what's safe to do and having the right specialist. The worst thing to do would be to have your complex fracture fixed by somebody who didn't know what they were doing, and then you'll have a lifetime of problems if you don't get it right. But many things, simple fractures and things, and I think there are plans to try and bring back the treatment. And so the overall idea, a bit like we've done in Millom, in that we're trying to bring services back as much as we can back for the people of West Cumbria to the local facility at Whitehaven. But within that, there are these specific pathway changes around children's and stroke and so on. And probably the most contentious, I would imagine, down here is the maternity side. But maybe I'm imagining it might not be. There might be other issues as well. So I think that's it. Oh yeah, decisions. I've touched on this. So there's been this mantra right the way through the success regime, right the way from the start, that no decisions have been made. And a lot of people said, oh, no, that's not true. You have made decisions behind the scenes. Well, what they've done, there's been a process and there's a number of preferred options. The success regime doesn't have the power to make the final decisions on this. It has to go through this legal process, and it has to listen to the feedback from the population. And only after doing that, and there'll be a lot of analysis to try and make the right decision. So whether the preferred options are things that might change. I don't know whether they will, but if it's not decided, but it will be decided towards in the first part of next year. And in a way, the longer in limbo, the harder it is to recruit and retain staff, and it's a real disruptive time for the NHS here, because it's difficult anyway. It's very disruptive when you're just going through, reviews. So, from my personal point of view, I quite like to, get through all this and then begin to be rebuilding the whole health system together in much closer partnership. So I think that's it, and we're going to take comments and questions and so on.
Okay, and there's the website I was talking about. Just out of interest, John said he knows everybody in the room. What do people from Millom call themselves? Are you Millonians, Millonites? Millomites. Are there any non-Millomites here? Great. And are there people here from organised groups, or are you here as interested citizens? You're both.
I'm an interested citizen because I live at Ravenglass, which is a real problem area.
Okay. All right, brilliant. And how many of you have accessed any of the material online? Have you had a chance to have a look at the website? Any views, any thoughts about it? A lot of information on there. Anybody read the 206-page business case yet? Because there's a test later on and you can't leave. So I think some of the stuff, however, that John's talking about is contained in that business case. There's some really excellent stuff about how they went through an option appraisal process. So if people are wondering how you got to these options, it is all explained in that document. But if you want to ask further questions about that, I'm sure the panel will help with that as well.
I think you should video John saying what he's just said and put it actually on your website.
Yeah, I think we talked about that, did we? About having a kind of video at some stage. That'd be nice for you, won't it?
Thanks for that.
Yeah.
Sorry, I was just saying I've learned more today than at the meeting up in Whitehaven a few weeks ago.
Oh, brilliant.
I've learned more today from John as to the reasoning around everything.
Okay.
And why the options are there than the whole of the...
Right, well, that's great. I mean, it's the second time I've kind of heard John, but he explains things very well. I'm sure the rest of the panel will do the same. Just before we get into that, can I just check about who wants to talk about what? So there's 5 kind of areas in the consultation.
I'm still on the website. I want to make
Oh, I'm sorry.
There seems to be documents still being drip-fed onto it, and there were some documents, I think, to come. So I'm wondering why the documentation wasn't ready when the consultation started. I'm from West Cumbria Voice Healthcare, which you might have heard of, and we are trying to study this.
Right.
It's putting a big load on a small group.
Sure.
And, if we don't know when the documents are going to be on, and they're coming on at a later stage, you're giving us a real problem
Sure.
in looking at this.
I mean, I think the issue about consultation is it's supposed to be a dialogue. There's never kind of a fixed point. There's times that you have to bring an end to certain parts of it, but there should be information coming online as much as possible, as early as possible. So I don't know whether the panel have got any views about if there is a gap anywhere and some of that information coming online shortly.
Well, the impact of transport, for instance, on some communities, on sort of equality of access. We've got
Sure. Is there an equality? Sorry, is there a transport analysis? I thought I saw that on the website. I think a transport analysis has been done. I don't know whether Rick, do you want to talk about transport at some stage? Is that all right? So can we'll have a thing about transport then. Was there a general question that you guys want to respond to in terms of the website?
The sort of things not being all on the website. So there was quite a lot of supporting documentation that have been uploaded when it's been ready, rather than already at the time of launch. So I think there are some imperfections in the process. So it's partly there's a group leading it, but there's only a certain number of people in that, and people for people like myself and others and colleagues here, we've there's 7. This is I think the 6th public meeting I've done in the last. Most of them have been in the evening, so it's put quite a lot of pressure. And there's 17, I think, public meetings, aren't there, coming into people's diaries. So I think it's not perfect in terms of the these things weren't ready for when the launch date. I think it's a fair. I think you probably know what I think, but I think it's not. I think it is a very important point to make and record that when you went to look at it, the background document, the fact sheets, some of the fact sheets weren't ready and uploaded and so on. I think that's a fair criticism, actually.
And it may also be some of that information is there. It's just not. It's not easily accessible, because, as I say, I think there's a lot of information contained in your business case, which includes some appendices, which include things like travel, and maybe that could be made more easily accessible to people. Okay, so we've got kind of 5 areas that are in the consultation document. We can take one away because John said that the community bed kind of reconfiguration is not necessarily relevant for Millom, although there are people here from other areas and they still might want to make a comment on that. But of the 5 areas, we've got children's services. Questions about children's services, anybody? Yeah. Maternity? Yeah. Emergency and acute care? Not so much.
I would really like to know why emergency and acute care are classed together.
Okay.
Because I think there are different issues surrounding both.
Sure. Can we actually ask the question in a second, because there's a guy giving me evil eyes about making sure that people are using microphones. So we'll come to that when it comes to that point. We'll do that then. And the final one is the hyperacute stroke. So you're interested in that. Good. So we've got a coverage of everything. So let's crack on. Shall we start with the one that we seem to have most interest in? That's maternity then. Who would like to start? This lady here.
I think when you look at the consultation document, it's obvious what people would choose, but I'd wonder how you bridge the gap between realising that and what people would choose in terms of the realistically. Maybe you could send somebody to Carlisle if you knew there were going to be problems, but if, say, an issue arose during labour and a woman needed to go and have an emergency caesarean, for example, whether it could, in terms of recruitment, financing, all the issues, you could get all your ducks in the row at a particular time, maybe in the early hours of the morning, to get everybody that you need there, the surgeon, the anaesthetist, the paediatrician, all the various specialists. And in terms of recruitment, how could you foresee, or is there any way of foreseeing that this would be realisable? So it's obvious what people would want, but can you categorise it in some way that you can decide at what stage a person would have to be referred to Carlisle, or whether you could treat it at West Cumbria? Thank you very much.
Are you guys right to answer that from the Acute Trust?
That's a very pertinent question, and I think you've probably asked the most fundamental question in the room. There will be stages in any lady's pregnancy where you'll be making an assessment with either your midwife or indeed with your consultant about whether or not you are classified in your pregnancy as a low risk when you're due to give birth. The work that would happen if a midwifery-led unit were to be situated in Whitehaven would be really important in those stages during a lady's pregnancy. So my understanding, and you have to bear with me because I'm not a doctor, and there may be people in the room who have a better understanding of this than I do. My understanding would be that a decision on whether or not a lady would be suitable to give birth in the midwifery-led unit, or indeed would require a consultant-led unit, the intention would be to make that as early as possible during that lady's pregnancy, so that the arrangements could be made for someone of a high-risk birth to be booked into Carlisle for that birth. Or indeed, if you live in this area, as John said earlier, you may choose, if you wanted to have your baby in Barrow.
Are you happy with the answer? Okay. Any further questions on maternity? There's a lady at the back there.
I'm Maggie Opie. I was community midwife here, started 18 years ago and retired 5 years ago. So I've seen maternity services to Millom be desecrated in the time that I've been here. When I first started, a woman that was pregnant had cover day and night. There was somebody on call locally that would see her. And now we are down to extremely limited clinics that girls from Whitehaven have to come and cover. I have no idea how they cover the complications that happen within the Millom women successfully. The amount of women delivering at Whitehaven has overtaken the Barrow ones, I presume, because of the fears of the baby deaths at Barrow. It's taken a swing around because when I finished work, the majority were going to Barrow and less to Whitehaven. It is all definitely run by money, as we can tell from it, but my biggest fear is that lives are at risk in this. Women and babies' lives are at risk, and it's no secret to anybody that a whole maternity service of a whole hospital can lose a lot of its money from being sued by negligence, especially to do with childbirth, because women and families are particularly sensitive when it comes to their children, let alone the mothers. You cannot define a low-risk woman through to delivery. The amount of women that become high risk during labour is the risk factor. To the thought that a woman in labour would have to be taken by paramedics any distance by blue light in order to have a section is, in my mind, and in that of anybody's, I would think, absolutely horrific. And you're not only putting a woman through a trauma. I have been alongside women being taken from Barrow to Manchester at high risk. It's a terrible thing to have to do, is to go on an ambulance journey of any length when you have got emotions involved as well as lives. And you take that midwife away from that unit the minute you do a transfer out. I wouldn't be worried about the early hours. What happens when the Sellafield traffic have turned out on this road? Our roads are not suitable to transfer a woman up the road with taking a midwife from the unit. What if you had two?
Okay,
what
just
are you
pause
do?
a moment, because I think you're asking about clinical reassurance, kind of reassurance about the model.
All of it.
But you're also
yes.
asking, I think, about the route network, the road network.
Everything,
and
yeah.
I think when I talked to ambulance colleagues last night, they were talking about a big investment from the service in that area. So perhaps you could pick that up as well, Rick.
Yes,
Could guys from the Acute Trust respond to the kind of reassurances around the clinical model that this lady's raising?
So I think the point that you raised from my answer to the First Lady's question was you can never know right the way through a lady's birth what is going to happen during that time. I can't argue with that point. You're absolutely right. But risk is inherent, obviously, in some of these areas. And the balance would be with our clinicians about how you de-risk that to the absolute level that you possibly could. I don't think any panel member could sit here in all honesty and say you can completely de-risk birth. It wouldn't be true to say that. There will always be an element of risk attached to that. but the clinicians working together, and the guidance that we have from our clinicians are that the decisions could be taken at an appropriate time for transfer. And I absolutely understand what members of the public feel and how people feel anxious about ladies in labour being transferred by blue light. That is a real anxiety. We absolutely accept that. However, we have to look at the global risk attached for all ladies giving birth so that we can do the right thing. So services currently are stable. But what we are saying as an organisation is we do not know that we can maintain that stability. And it is almost more sensible to plan than to have to say very, very short notice, we need to change our service model for maternity or for children's services. We wouldn't want to have to do that almost overnight if we, for example, lost some of our locum paediatricians. That would be a worse position to be in. So the consultation is about making a planned change. There would be an awful lot of work to do around those risk assessments and those balances of risk and how you worked and how we worked with our midwifery team, how we worked with our consultants, if a decision was made that that was the preferred option.
Could I just double check people? They might have the same question, but presumably these clinical pathways you're talking about have been consulted on outside of the trust. You've had the Royal Colleges look at it, and you've had, I think there's groups of clinicians that kind of meet on a regional basis. What are their views of what you're trying to do?
Their views are the same as ours. If you could maintain a consultant-led unit on each site, that would absolutely be the preferred option. But the Royal College of Obstetricians and Gynecologists have advised us as an organisation that if we are unable to stabilise our services that we currently have and maintain 2 consultant-led units, it is beholden on us to look at the option of a centralised consultant-led unit. So that is the guidance from the experts, not the opinion of myself.
Did the Royal College of Midwives
Royal
advise
College
you?
of Gynaecologists have advised us.
Is there a Royal College of Midwives?
There is a Royal College of Midwives.
Yeah.
Did they take into consideration where we are positioned in this county?
Yes, they came.
Is it based on, in London?
No.
Is it based on our isolation?
No, they came to visit us. I mean, because of the rurality and the very great travel distances that there are across the whole of this Cumbria patch, we asked the Royal College specifically to come and visit us, and they visited both units.
Could we just ask Rick to talk about transport,
Yeah,
because it's come up a couple of times, and then we can come back and see if someone's got a different question. Is that all right?
Yep, certainly. I think I'll just echo what Helen said around the Royal College as well, is that NLAS was heavily involved in that review. We sat on the panel, and all the specialist clinicians from that Royal College were in Cumbria regularly. So they were very aware of the road system, they were very aware of the distances, the geography, the demographics were taken into account. It was a massive piece of work that did take the things you worried about into account. So just some reassurance on that one before I go on to transport. In terms of any new models, we'll work closely with our partners to make sure that risk management is absolutely sure about how any new services work. We've looked at models across the whole of the UK where this has had to change in a similar way. We're actually going down to Wales in about 3 weeks' time to look at a service in Pembrokeshire where a hospital's changed from a consultant-led to a midwife-led unit, and what they've done in terms of ambulance provision to provide safe transport for that. That's been in place now for over 12 months, and they look after several services with a dedicated vehicle that's based at the site all the time, 24/7. So in terms of options, that might be one we pursue for the future. And the multiple transfer aspect of that is something that's also being considered both for acute staffing to come with us and provide expert support to our crews during that transfer should we need to do it. But I think looking at how many people, it will be a very small proportion of people, and whilst that's not reassurance, the numbers involved are very small. So yes, as an organisation we're heavily involved. Yes, we're looking at multiple solutions. Yes, we're looking at solutions that have already been implemented and implemented safely with Royal College reviews against them because there is a Royal College review against the Wales service, that having been running a while now. So onwards, and for us, we will see what the preferred option is when we get to that point, and then we can do the work required.
Okay. Can we just hold on 1 second, because I think there's a few other people that want to say, and we need to use that.
Comments to finish on that. One is, I think the home birth list will go right up. I think it's so wrong to say the home birth assessment of how many people will want to stay home will stay the same, because I think women, given the option of having 2 midwives in their own home, will stay put. So I do think that that is wrong. And the other comment is, well, two. There's one, I think that you need to take the trauma to the midwife. If a midwife is going with somebody high risk to get from Whitehaven to Carlisle, and something happens to that baby en route, she has no other staff support. She has nobody else there that she would have on a unit with other staff around her. She's a person with nobody there that's got any other expertise. You can't get more people in the ambulance to sort it out than the midwife. And my third point was just that John said, if you get a fracture that's wrongly set, you have a lifetime of problems from it. If you lose a child, you have a lifetime of problems.
Thanks very much. And, yeah, well said. But I also think those points you've made, they've got to be in writing, because we'll take the audio from today, but they're really good points. When you make those points, there's got to be a record of them so that they can be counted as part of the consultation. So please, if you've got stuff that you feel strongly about saying, get it down on paper, because we've already got a commitment that people read this stuff, and we'll come back to kind of how this process finishes in a second. Can we move the microphone down a couple? There's a lady there.
It does sound as though one of the big issues with maintaining a consultant-led maternity service is actually paediatrics, that it's actually the lack of permanent paediatricians that is the issue, rather than lack of consultant obstetricians. It's just the impression I'm getting from some of what's been said. And if the paediatric services at West are stabilised, is it likely to become easier to recruit? Because as a parent of a junior doctor, I would not want my daughter to be taking a post anywhere where nobody has any job security, because all the units are up for review. If there aren't proper contracts and there aren't proper long-term plans in place for the units, is that not creating some of the problems we're having to now legislate for?
I think the recruitment issue, the workforce issue, John, you picked up yesterday, but I don't know whether, guys, you want to talk about this, because it's wider than just the paediatrician issue, isn't it?
It is. But you're absolutely right. The problem with stabilising paediatric services has a major impact on the decisions we're making and having to make in maternity services. And exactly, it's the risk is that because we haven't got a paediatrician available, we can't, we're then worried about women in labour. Paediatricians are in short supply nationally. They're really struggling to recruit paediatricians in the whole of Cumbria, not just at West. If we could stabilise it, that would be great. Talking to my paediatrician colleagues, it's very hard to be optimistic about a full substantive workforce of paediatricians being re-established at West. It's some of the issues that John mentioned with people getting towards retirement. It's the fact that there are units all over the country looking for paediatricians, the fact that people who are relatively recently become consultants are looking for jobs in bigger units which have more support from colleagues, which have much more appealing rotas. So one of the issues is that the paediatricians are having to work what we call a 1 in 4 or a 1 in 5. So every fourth or every fifth night and weekend you're on call. And that's substantially more than a big unit where you'd be maybe on a 1 in 12 or a 1 in 15. And that's a frightening concept for a relatively new consultant. And when there are jobs available all over the country, it's really difficult. It's the same issue with acute medicine, which is the area that I work in, that it's very difficult to attract substantive consultants. There is less uncertainty about acute medicine, although that's the area where the CQC were most concerned in the last visit, we're all committed to there still being acute medicine at West, and that's a preferred option, and that's what everybody wants, and we do believe can happen. But even with that certainty, and with what are actually quite exciting developments in terms of what we're calling the composite workforce, which is something that I actually think we can take out, and I'm hoping that in 5-10 years' time, people from big cities will be coming and going, how did you do that? Because we haven't got any doctors now, and you managed to solve that problem. Even with that, even with what we are very confident is a very exciting and viable model, we can't get substantive consultants. So I've been at West nearly 3 years now, and we have not recruited another consultant in medicine at West, despite continuous trying. So it's a pessimistic situation for the paediatricians, for the general physicians.
You can. Could you hold on one sec?
Just talking about recruitment, and I really know it's a countrywide job, but like you say, if they're not permanent jobs and allow people to get training, who would want to come? Surely that's the issue, and that's what we should be looking at. How we can get people to come here and train them. And we've got the medical, college starting. Surely West would be ideal for them to...
Yeah, so the issue in medicine is that because we didn't have enough substantive consultants, it was deemed by the Royal Colleges that we could not have trainees, medical trainees, junior and middle grade doctors. That's not the case in the other specialties, but you're absolutely right. The current model of doctor training nationally is such that we are not allowed to train people. Now, that's very frustrating, and it also seems from the inside very short-sighted. We're reliant on locums, but many of them are junior doctors who are taking a break from a training program somewhere else, and they report getting fabulous support and experience and training working with us. The work we're doing with UCLan, which is the university that John talked about, with their medical school, which follows a slightly different model, and to my mind, more importantly, and certainly larger in terms of numbers, are the non-doctor clinicians that they're training. So that's nurse practitioners, physician associates, to produce a workforce of people who may not necessarily have been doctors, but they are extremely well trained and competent to do the job that we're asking them to do. And actually that's where the future is. The problem is it actually takes years to train somebody from, so most people going to those courses have got a degree in a relevant subject. So they've got a degree in biochemistry or something, for example. So to go from that to fully trained, clinically competent and experienced enough to be carrying the can is many years' work. So we're at the beginning of that process, and I am optimistic, but it's not an overnight fix.
John, and panel, I'm right in thinking there's a number of work streams which are outside of the kind of consultation, and kind of workforce planning is one of those, because the integrated care communities, we're not really talking about that in the consultation, but that's a major issue that the success regime are planning. So there are a number of things that are going to come up on sessions like this when you're talking to people that in a way that you haven't got a voice at the moment, but I'm sure if you have got a voice and you want to make it known around things like workforce planning, that the trust will be wanting to hear from you.
The composite workforce is detailed in the acute medicine section of the consultation document, so there is information about it there.
Thank you. John?
I was just going to say something briefly about the medical school. The motto we're meeting all today and all yesterday about building the medical school, which is at West Lakes. There's a campus of the West Lakes Science Park. And we're trying to break through because they're increasing nationally the numbers of doctors trained. Now, UCLan can only recruit overseas students at the moment. And what we want to do is to break through and get UK students with a sort of mantra of from here, trained here, and working here. Because if you can get people from this area, train them up, and then they're going to most likely stay or very often stay. And there are medical schools around the world that have really just purpose themselves almost like a social responsibility. One of the key responsibilities of that is to generate the workforce for the future. But it's going to be a long lag time for this, and it's going to take quite a long time to switch on. Just going to say something very briefly about the actually, and you mentioned it, is actually feeding back in the feedback. There's forms at the back and also on the website and so on. The views, here, particularly of the people of South Copeland, because South Copeland is the area that's, of the changes, it probably impacted most. Because if you if you were living Dissington, well, it's not quite. It's inconvenient. It's a bit further. You live where I live in Cockermouth. You know, we can go to Carlisle just a bit longer than it is to go to Whitehaven. The further you get here, there's like a watershed where there's a point where people in Millom could and probably would mostly move back down to back down to Barrow for the care if the consultant led was way up in Carlisle. So that's the likely impact. And things have, I believe, because we work quite closely with the Acute Trust in Morecambe Bay, have very, very significantly improved around that unit in Barrow. They've put so much effort and attention to it. But it shifts that watershed line up a bit. Whilst here it's still a viable option perhaps to go down to Barrow, you get to Ravenglass or you get further up, it's almost like the watershed's shifted where you get to a point where it's a long way to go to Carlisle, and it's a very long way to go to Barrow. You know, but that point gets further up into South Copeland. So getting the views in and the comments in are really important for people to consider.
Just 1 second. Was it a quick one? Because this lady's had her hand up for a while.
I've got a separate question. This is just a quick follow-up to this interaction between the paediatrics.
If you do the quick follow-up and then this lady's next, is that all right?
Very quick follow-up. So children's option 1, does that support maternity option 1, but children's option 2, the other children's options don't? Is that correct? So children's option 1 is the development of focusing on West Cumbria, but there's still children's services at West Cumberland with some inpatients. Okay, so which of those would support maternity option 1 and which would not? Because it's related, isn't it?
It is related.
Yeah.
So the realistic answer would be if there could be a full paediatric service with fully established paediatricians on a rota 24/7, that would support a maternity unit. So that would be maintaining inpatient services on both sites.
I think from I'm the out of hospital bit of this whole program, but from my understanding, I think option 1 is even a step down from what you're talking about, Helen.
Yes.
Because it really is reducing the risk of people who are treated there. So I think the staff modelling and so on that you would have to do to support maternity as well is a step up from there. Is that right?
Yeah.
Is that a clear enough answer?
I don't think it quite cuts, if you see what I mean. I think there's almost a 0, which is a all singing, all dancing, 24/7 paediatric rota that would be the one that would cover the maternity, as far as I understand it. But
is that right?
That's right.
Okay. This lady's been very patient.
Jenny Brumby from Millom Health Action Group. I've got some comments from people that can't make it today, so I've got some. I'm going to try and integrate them. Quickly, a point to you, Rick. We love our ambulance here, and we'll always fight to keep our ambulance local. What's a major issue for us is if you go up to Carlisle with our ambulance, you are locked in up there, potentially being used up there, and we are not covered here. That's true. That takes us away just on one journey up there for 2 hours. Then it stays up there for however long, and then it's possibly 2 hours coming back. So that's 5 to possibly 6 hours that our ambulance will be out of town.
Do you want to do all of the questions
Yeah,
or
sure.
you've got, and then we'll kind of
So the next
parcel them
one,
up?
which is probably the biggest one that we get asked all the time and we don't have an answer for, is they are building a new maternity unit in Barrow. And as John said, 60% of people in Millom prefer to use Whitehaven Hospital. The town's consensus is that we will be forced now to use more Barrow maternity services because of the new system that's been set up there, which will ease the burden on Whitehaven and Carlisle, because we will not have Whitehaven as an option anymore. Can you clarify if that's actually a plan?
Okay, so just the two questions then. So one about we're going to lose our ambulance because it gets stuck at Carlisle, and one about this is about forced to use Barrow. Do you want to do the ambulance first?
Yep, certainly. In terms of any changes under the proposals and the decision that is finally made against what they are, then, as I talked about earlier, there is provision throughout the document for additional resources for any change in services. So, for maternity, for example, the option of a dedicated vehicle to undertake that additional workload that may occur.
A dedicated vehicle just for Millom?
No, not for Millom, for that part of clinical services. So that...
You still have to come down from Whitehaven though to cover Millom to go back up, is that correct?
No, because we'd then use a local vehicle.
Which could potentially take us out of town for 5 hours.
But it's not a ring-fenced vehicle for Millom. It's a North West Ambulance Service resource which will be used appropriately for the people of the North West. You know, Ulverston last night were working in Manchester is a prime example.
That's what I mean. It's the
do you have an ambulance now? Is there an ambulance now with Millom?
Yeah, we have an ambulance, but unfortunately the system locks you in if you go to a major area, and we know that, and we're not covered once that happens, or other areas have to cover us, and being so isolated, it is a huge...
So there's a designated ambulance at the moment for Millom, is that right?
There is. There's a vehicle station in Millom 24/7, and then an additional 37.5 hours of a specialist community paramedic based here as well, which is another recent appointment.
When they come from away, they can't always find you. I can tell you that. I have stood at the end of a road in Southcroft, flagging down the ambulance to take somebody in.
Sat-navs aren't very good in these areas. The postcodes are huge.
I presume you've got ways of getting around that.
Some significant infrastructure and IT around finding addresses, and for addresses to be flagged to us by communities where they are awkward to find, so we can actually flag them on the system. So there are find my postcode, etc., available to the public for those awkward to reach areas that people are concerned about.
Okay, John?
Just for information, there is in the proposal proposed a dedicated ambulance, like a shuttle between Whitehaven and Carlisle, but that doesn't mean that ambulance would come down here and retrieve people in labour. I don't think the plan is for that. It's actually that moving for people at the midwife-led unit who get into trouble having their own dedicated transfer. Is that right, Rick?
Yeah, I've started to look at the operating procedure, the devil in the detail of the service that works in Wales, which is why I'm going down to look at that. And they cover obstetrics, paediatrics, maternity. But within this, in the operating procedure, it also gives the opportunity for that vehicle to be used locally should the need arise. So it's the nearest vehicle will always be sent, I think, is the reassurance that I want to get across to everybody. You know, that our nearest available resource will be sent along with our community resources until we can get a vehicle there. And we do have some outlying communities where distance is a problem. You know, Millom is isolated out here, but there are a lot more across the rest of Cumbria. Alston, for example, is even further away. No, but they have, you know, a significant community, and it's even more isolated. And there are several other areas as well. And, you know, I appreciate the concerns, but as reassurance, we will always send the next available resource and the nearest available resource.
Okay, can we do we're being forced to use Barrow, and then I'll come back to you. Is that all right?
Thanks, John.
There is no force. There's not forcing to use Barrow, but practically, sensibly, the options of where you might go narrow down. So, of course, people could still choose to go to and deliver in Carlisle, but would you? You wouldn't, would you? So, for consultant-led, slightly higher risk births, you would go to the nearest consultant-led maternity unit. There is, of course, the option, the midwifery-led unit at Whitehaven would be a definite option for people here that wanted to deliver in a midwife-led unit. Now, when you actually look at the numbers, I think is it 300 to 400 or something so most women would not fit into the low risk category to go to that unit. But the choices to do would still be there. It's just practically, it's not really a choice, if you see what I mean. If the choice for if you're getting a higher risk birth, then you would almost certainly want to go. You would constrain your choice and go to the nearest one, which is Barrow, because it would be significantly shorter journey times and travel from here up to Carlisle.
Okay, there's a lady in the other corner. Can you?
One more point. It's gone up. One more point before, and I promise I won't speak again because I know I do speak a lot. I was at the meeting up in Whitehaven a couple of weeks ago, and Jamie Reid said, if you want to retain the services that are at Whitehaven Hospital, please put a line through the consultation form and put retain services. Can I just check officially that if people do that, are you defacing the document and it won't be added in? Because he did say that in a
no, I think these would be. I think they're feedback, aren't they? Do you want, Elliot? Do you want to say anything?
Right, that's fine. It's just that's just something that he said, and it was, I just wanted to clarify that.
I think the question about how to feedback came up yesterday as well. As far as I'm concerned, and I'm sure colleagues would agree, it's getting feedback is important.
Okay.
Almost how it comes in is not so important. So if you want to write on the side of a cow, that's fine. If you can get the cow into the post box.
Thank you. Could I just incorporate the two questions? My main issue is the maternity being retained at West Cumberland, and the second one is Jenny's ambulance service. I know we have an ambulance in Millom. I have a 5-year-old diabetic great-granddaughter who had to wait 35 minutes a fortnight ago for an ambulance to arrive. Her mother had the sense to run to her sisters who lives next door to one of our paramedics who saw to her. And the other issue is we are looking at ambulance times from Whitehaven to Carlisle. We're not looking at the Millom to Whitehaven and then from Whitehaven to Carlisle. In between going from Millom to Whitehaven, there could be some great risk if our ambulance could be anywhere, and the ambulance had to come from Ulverston on that Sunday night. It was sorted, she was blue lighted to hospital, but it was 35 minutes before an ambulance came. Now, if that's a lady in labour who has had a perfect labour, perfect readings all the time she goes, nobody knows what issues are going to occur during your labour or during the birth. So from us having to wait maybe 30 minutes in Millom to go to Whitehaven and then on to Carlisle, to me, is quite my main issue. I will take my chances wherever they take me. I'm at an age now where if they take me wherever, if I've had a stroke, I'm not really bothered. I'm worried about the young ones in this town who haven't really known anything about. They don't look at consultation things. If they haven't got something pushed through the door to say, do you want to retain these services? I've phoned 2 of my grandchildren. They didn't know anything about it. That's their fault because they don't look at. But a lot of the younger ones, and I've just asked, I said, I'm going to a meeting now, and they're going, oh, what's that about? And 90% of the people I have told haven't got a clue. So that is my main issue, is the ambulance service from Millom and retaining the consultant-led maternity unit at West Cumberland.
Right. Is there any further kind of reassurances that you want to add about the availability of ambulances?
I can't really say any more about, the ambulance service is part of the consultation in terms of changes to the system, not about local level response times. Any changes may impact on those local level response times, and what we're doing with the consultation is making sure that our services are maintained at the levels we have at the moment through the implementation of additional services to cope with any change.
Okay.
In terms of local level service delivery, then I'm happy to talk. I can't talk about individual issues, obviously, but I'm happy to take that outside of the meeting and talk to the community about that in detail, as I've done before.
Does that seem fair in terms of if there are issues generally about the ambulance service and response times, Rick will take those outside of the meeting rather than now? Is that okay with everybody?
So say
Go on,
something
John,
just
and
to add, Rick sits on our Millom Alliance and comes to our Millom Alliance meetings, and we so it's quite complicated how you keep an ambulance local, isn't it? There's lots of things that we need to do. We need to avoid it going to Manchester, but I do understand, I think, a little bit of how you move your resources around and reposition things and so on when you do send one way out. But one of the things that we've been working on together and through around the COOM and all the other things is to how do we keep the ambulance, because once it does leave, it's a problem for us here. How do we keep it here as much of the time we can, and so there are issues about using it for the right things, using it for actually having alternatives when people ring and then they're assessed that they don't have to then travel to A&E when you could travel to the local doctor's surgery instead. And there's lots of examples of how we're working like that with to try and keep it here. And just as the ambulance station is part of the planned rebuild of the GP surgery here, so we're actually, there's no plans at all, as far as I understand, Rick, is to remove the ambulance from Millom. Far from it. We are rebuilding the nice, lovely facilities for our ambulance colleagues here in Millom to make it a great place to work.
Did you want to add any further?
Yeah, I just think to reiterate, we'd welcome any opportunities. We've always done with Jenny, with the community, to discuss how things work and give you a better understanding of what we're doing as an ambulance service. I think it's really important that we take that agenda forwards. There are a lot of changes. We are doing things very differently, and it does mean significant change in pathways, etc., which are 2 hours worth of me standing in front of you and talking through those and explaining and giving you the opportunity to ask those questions. Happy to do that anytime. If you want to feed into Jenny, Jenny will link in with me and we'll do that at your convenience.
Presumably it's also communities doing stuff for yourselves, so that thing about the FAST campaign is because ambulances aren't always going to be there. You were going to ask a question about acute and emergency, weren't you?
I was, but I've got one more question.
Yeah, please.
About accessibility.
Okay.
I think the success regime hasn't actually considered the road transport. And I know it isn't a prime. I know it's not a prime concern, but it is a factor, and it's a part of the risk mitigation. We live in an area where we can be closed, we can be shut off. If Dudden Bridge fails, we can't go south. We can't go south to Furness General. And it has happened in the past, then people are diverted. They may have already booked into Furness General for care, or they may have booked into West Cumbria for care. But we've got 2 bridges that have failed us in the recent past where we have been isolated. And I know it isn't an NHS major concern. It's road and it's infrastructure, but it does have a bearing on the feeling of this community about the additional isolation we can get in adverse weather. And I think the success regime do need to take this into consideration. We were talking about risk and the balance of risk, but that is a key factor in the mitigation of our safety in this community, in my opinion.
Do you guys know whether the risk, there is a risk analysis in the documentation? Was the transport issue?
You want me to?
Please, if you could.
Under the transport work stream, which is looking at not only emergency transport, but planned transport, community transport, volunteer transport, and we have representatives from the community groups, the council. There's a huge piece of work going on, and I think it comes back and links quite nicely to your question about why isn't all that documentation there. Those groups are still working and are still producing information and packages that are changing daily. I sit on that group and we met a week ago, so there's a new piece of information coming in the very near future from that meeting about the work we've been doing. In terms of business continuity, then, the emergency planning side of every organisation, John's, Helen's, our own, and all the other services, make sure that in terms of access, we plan to make sure we can access and we can transport. So there are significant business continuity plans, emergency and resilience planning that goes on along with exercising that, not only at tabletop level, but at an actual event level. We're heavily involved in that all the time. Prime example yesterday, 15 delegates from MWAS into BAE Systems to make sure we understand their systems processes, the lie of the land, where all the systems are within the yard that we might need to use. So that's just an example. No, it doesn't relate to here, but it goes on for here, it goes on for Sellafield, it goes on right across the county.
John, quick point, and then I think there's a couple of
just
people
going to make
to
the
ask.
point that the community groups right at the beginning, when we started working together, surveyed the town and surveyed the town on other things as well, and out of house care recently as well. And one of the key priorities, which really struck me, was how important it is that ambulance, and Rick knows because he's been part of the whole journey of just to add to the transport discussion, transport's much more complicated than looking on a route master and working out what the travel times are by car on a road, on your average road, because it doesn't work like that in Cumbria, does it? Because the roads aren't average, they're rubbish, and also there's all sorts of weather and other issues. The other big thing is that I was in Maryport a week before last talking to the community in a meeting like this, and the Newrenrig estate in Maryport, 46% of the households don't have a car. So you think, well, transport, it's actually, then you start to think, well, it's public transport then, isn't it? And the public transport we know around Cumbria is really challenging, and you know, so somebody said in Maryport, well, you can travel to Cockermouth Hospital, but there isn't any public transport links between Maryport and Cockermouth. Can you imagine it? There isn't one. There isn't a bus. There isn't a train. So they have to go to Workington, you know, and it's sort of and similarly here. I understand that the train links are not great for appointments and so on and so forth.
As a visitor to the area, it's not all doom and gloom. You know, there's a fabulous place up here. Because it's making it sound like, oh my God, it can't get anywhere, and the weather's terrible, and well, weather might be terrible, but this lady had her hand up. Just to check, we haven't talked about acute and emergency, and we haven't talked about hyper-acute treatment times, etc., which probably links into something we were talking about there, really, in terms of access to specialisms and etc. Is your question about any of that? Right. Okay. Okay, let's try and do some final bit on maternity, or well, not final bit, but conclude this bit on maternity, and then if people have got any questions about those other two areas, we'll take those, and then we'll come back and make sure we finish up.
Okay, so it's a different question about maternity. When I was in labour with my first child, I had a 40-minute transfer to West Cumberland Hospital. And the first time when I went in, my labour didn't progress very well, and they told me I hadn't been in established labour when I came in, and I went home. The second time I went in, I was clearly in regular labour. I was past 2 centimetres dilated. I went in, I did that journey again, and when I got in, as a result of that journey, it seemed I then kicked out of labour and then had to go home again. Now, I was told at that time that the definition of established labour is that it doesn't kick out when you make a journey like that. Therefore, I hadn't been in established labour, but my perception of that situation was that the journey had interacted with my labour and had compromised it. Now, is there well-established research on what happens as you have longer journey times during labour to the experiences that women have in being able to sustain that labour or then kicking out of labour? Does that exist? Because it didn't seem to exist at the time. That was 13 years ago. Nobody seemed to really have a grip on that at all. It was like, well, you know, I went in today because my mobile phone screen is cracked, and it seemed to crack overnight while it was on charge. But they say you have no statutory rights for that being a manufacturer's fault because it's considered to be traumatic damage, and therefore you must have damaged it. Well, that didn't happen. And it was like that with my labour. It kicked out of labour because you weren't in established labour. But
so the question is about what's the clinical evidence
about
that supports the
that
pathways.
Supports,
right.
that you can make an hour and a quarter journey in labour safely and it not do that to you.
So rather than that, it's not about that specific, is it? It's a more general question about what's the clinical evidence behind the pathways, I suppose.
Well, no, it is what's the clinical evidence, the research about the experiences women have in labour and kicking out of labour with long journey times?
I don't think we could answer that because we're not experts in obstetric delivery. But it is a very pertinent question, and I think one that we would need to feed back to our obstetrician colleagues to answer. So I think all we can do is potentially gather that question and put some feedback on that.
So you can put that
unless
onto
anyone
the
else feels more expert to.
You can put it onto the
say
FAQ
that.
of the.
I'm sure we could put it onto the FAQs.
I'm a community midwife here in Millom at present, and I don't know about journey times affecting how your labour is progressing, but there's lots of other factors that affect your labour progression. I think sometimes if you're in maybe a highly, you could be frightened because you don't know how long it's going to take to get into hospital, what things you're going to come across. Other things that you wouldn't think about can impede on your labour, because it's all about the release of certain hormones, and they can be affected by how you are mentally, not as much what's happened physically. So I would think that could have an effect. It could, if you're in a heightened anxiety state, worrying about how long your journey is, you've got to get to that hospital and what might be happening to you and your baby. So that can have a negative effect on labour.
So I was saying that we need to make sure that there's more information available to people about the clinical evidence, but you've asked a specific question about the clinical evidence as it relates to travel times and pregnancies.
Yeah, I don't know about
So if we can get that put into the public domain somewhere, I think that would help. Absolutely. And I think there's an agreement to do that. Okay, anybody got a question about acute and emergency?
There was a question about the definition, wasn't there, which was... shall I take the definition question, because you asked that earlier on? So it is a bit confusing, and some of us in the field find it a bit confusing. There's a lot of people now refer to anything that happens in A&E as emergency medicine. So that includes things like, a deep laceration or somebody exceptionally drunk or whatever, and all of that, for a lot of people, is now lobbed together under the title emergency medicine. Acute medicine is what sometimes people call general medicine or general internal medicine, which is what I do, which is a medical as opposed to a surgical or indeed obstetric problem. So, for example, pneumonia, diabetic emergencies, urinary infections, stroke, etc., is acute medicine. So it is confusing, and it's not obvious what the difference is. But by acute medicine, we mean strictly medical problems, emergency medicine, anything that might ship up to any.
Are you happy with that? Right.
All right.
Say
okay.
why you're not
Sorry.
happy.
Sorry, that was very rude of me. I was very happy with your explanation, and my apologies for my, I just find that there may be issues surrounding A&E and acute medicine that are entirely different, because take, for instance, we need speedy access for A&E, don't we? That is a key. But there again, there are different issues with people. Take geriatric care. Here in our community, we are finding more and more people are being shipped north or shipped south for that care, because we do not have the capability within our community to deal with it. That creates problems, more long-term problems and issues for family, for friends, for people who are supporting those individuals accessing care. Now, I take that as different priorities and different issues to anybody who is commenting on things that are related to accident and emergency access. And that is my concern within the consultation. We're talking about business plans, all sorts of things. The general public, the people who we need to have access to say how they feel about care, healthcare here in our community, are going to be confused. I'm used to consultations and I'm used to documentation. And I'll tell you something, I'm afraid I have been very, very confused by the consultation so far. And I can't, I'm not only rude, I make confessions. And I just think, we're not doing the best we can. And I just would like those two aspects to be quite separate and quite different.
Sorry. From the way we provide services, they're connected. So and I'll come back to talk about older people because that's incredibly important. And from my point of view, that's the area I work in, and that's also the vast majority of people who are admitted to hospital are older people. When people with medical problems, so take pneumonia, for example, are admitted to hospital, some come via their GPs because they've gone to see John and said, this is the problem, he's got pneumonia, you need to be in hospital. But many present through A&E. And so that's particularly out of hours, which is often where the staffing issues are. So we are, I guess, particularly, it's almost not a problem if John rings me up and says, I'm seeing this lady, I think she's got pneumonia, will you see her? That's absolutely fine. It's the kind of unselected people who have not seen a doctor or a nurse in their local facility first who come through A&E. So you're absolutely right. From the outside, they look very, very separate, but actually from the inside, the majority of people we admit under medicine are coming through A&E. Just on the topic of older people, actually a very big part of the success regime work is what we're calling frailty work, and that's about acknowledging that there are many people in the community throughout the area who have a complex group of needs, which may include acute needs, but often a lot of chronic diseases which fluctuate, social needs, mental health needs, and those people, from the secondary care point of view, we have a tendency just to put those people in the beds and give them antibiotics, and we increasingly know that that's often counterproductive, and a lot of us are trying to look at working out when people really need hospital care and when it is detrimental. And we know that older people particularly, become muddled in hospital, they lose muscle strength, they're away from home. I mean, it can become a downward cycle very, very rapidly. And so some of the things we're looking at in the frailty work stream are about identifying people at risk of frailty in the community before a crisis occurs. And that's frailty, physical, cognitive, across the board. And then when frailer people are admitted to hospital, making sure that people with expertise in that area see them very, very quickly to work out actually where the best place is for them to be looked after, because increasingly we think that is not an acute hospital. Now, equally, we can't have a position where we say, right, well, you're over 90, so you can't go to hospital and have this treatment. So we need to make sure that everybody has equal access to the most sophisticated treatments at all hours, but that we can step people out into the right environments, whether that is local hospitals or whether it is home with support, as quickly as possible before the detrimental effects kick in. The frailty stuff is a bit of a no contest, really. So it's not in the consultation because it's obvious that we should be doing it. They're doing it all over the country. A lot of different models are being proposed in different areas depending on what local systems are there. But it is something that me and my colleagues are spending a lot of time working on.
Guys, just at the risk of further complicating this, there's a new phrase which is in the documentation which talks about an urgent care centre. Do you want to... Would that help to explain that, or are you looking at me daggers and saying...
So that... John, do you want to take that? Because it is going to confuse things.
I think reassuringly, the proposals from the success regime keep an A&E at West Cumberland Hospital and acute medicine. So all the medical services that John was talking about are all still there. Now, we're going to have to innovate around the staffing model around that to sustain it and so on. But if we get that right, then it will be really sustainable for the long term. We won't be relying on junior doctors coming and going, spending a short time here. We'll have homegrown our own, increasingly expert nurse practitioners and physicians associates, which are like nurse practitioners. So, the other options, I think, what we'd encourage people to do is to support that as an option. That's a preferred option in the success regime anyway. And the other options of having downgraded urgent care centres and so on, most people who've lived and worked here, for a long time, would find it quite difficult to support that for this significant population of people along the coast to remove the access to a proper A&E and a proper medical service.
So do you guys follow what the kind of preferred option is from the success regime then?
That would be in...
I'm sure, I doubt if that's a technical use of the word proper. There are models around the country of urgent care centres, so you might have less A&E consultants or none, even might be GP-led units. They wouldn't be able to deal with the breadth of issues and trauma issues like our A&E at Whitehaven can. So it's a very much a downgraded. Sometimes they don't work 24/7, Kendal would be an urgent care centre. I think that's fair. Yeah, and we run that service in my trust, and it runs in certain hours, and it's GP led, and it doesn't have all the diagnostic support behind it with scanners and everything. We've got an X-ray, but we know we can't do a scan to check if someone's had a bleed in the brain or something like that. So. Oh no! In Whitehaven, we're talking about an A&E with all these things around. Yes, definitely. And there's quite a lot of us who die in a ditch over that.
I think we're going to have
hopefully don't die in a ditch, but
I think the idea of proper is going to kind of enter into the vernacular now. Has anybody got any?
Can I take a question about stroke, actually? Because I think that's the one area. I think you wanted to ask about stroke, is that right? And I think that's the one area where there will be a change to what I call acute medicine at West. So I don't know, if people are interested, I'm happy to talk about that.
Yeah, I think people are nodding, yeah.
Yeah.
Yeah, I agree. It's a lovely area.
Yes.
It is a lovely area. Have I got this on? Yeah. I found that a bit difficult to take because many of us are quite frightened, and we're being asked to balance living in a lovely area against what we see as an increased risk being imposed upon us. So I just wanted to make that point. On stroke, I think the people who live probably south of Egremont and from Bootle up will be at increased risk as far as stroke's concerned. I'm struggling with this. Bear with me, it's a very short story, but it's a personal experience, and it really matters. My husband had a brain hemorrhage in his early 50s. He wasn't living here. Well, we were away at the time. He was taken to a centre of excellence fairly quickly, and everything went well. 2 years ago, I had a car accident on the A595 outside my house. It took 40 minutes for an ambulance to get to me. It then took, I'm not quite sure how long, but at least 15, 20 minutes while the ambulance driver or the paramedic tried to find a bed for me. It was a case of either driving to Whitehaven or being helicoptered to Carlisle or to Barrow. If you take that into account and then you think it's going to be more than, generally it's an hour at least to get to Carlisle, and then somebody has to have the scan and the assessment. That to me is frightening. I'd like to move. So can you give me some reassurance is the question.
So I think people do worry about what we're talking about, thrombolysis. So that's clot-busting treatment for certain kinds of stroke. And the fact that there is a window of time in which that treatment works, and outside that window of time it doesn't work, and whether by not being able to offer that treatment at Whitehaven, there will be people who live south of Whitehaven who would have benefited from that treatment who might not benefit. Thrombolysis, clot-busting treatment is not given to the majority of people with stroke, because the majority of people are not eligible. It's specific kinds. So, for example, you talked about your husband having a brain hemorrhage. You probably know it's not used for treatment of brain hemorrhage. And there are...
but his brain, he was getting hydrocephalus and causing damage. Time matters then as well.
It does, but that would actually be managed in a neurosurgical centre. So if that happened, he would have to go to Newcastle. So that's where that happens. So the majority of people who have a stroke don't get thrombolysis. The type of stroke they have is not treatable with clot busting therapy. We do know that concentrating all your stroke resources in one centre or into a place that can offer 7-day-a-week services seems to save lives for people who don't get thrombolysis as well as for people who do. So when we first looked at the data from what we called HAZUs, hyperacute stroke units, the assumption was it was because people were getting clot-busting treatment, but actually the benefit, the survival benefits and the full recovery proportion of people who get a full recovery also goes up in those people who don't get the thrombolysis. And it's because we can have specialists on hand 7 days a week. That includes doctors, but also people like speech and language therapists, trained physiotherapists, to deal with some of the very early complications of stroke. We think, and all the evidence suggests, that by having a HAZU where we can offer those 7-day services, more people from the whole of the area will benefit. So you could say to me, I live in Ravenglass. If I have a stroke, I have to go to Whitehaven, which doesn't have a HAZU, even though you know that a HAZU would give me a better outcome. Why can't I go to a HAZU even if it's further away? So it's not that there is a concern that there are small numbers of people who will not get access to thrombolysis, but a larger number of people will benefit if we can get proper 7-day services working. It's not just stroke, actually, it's TIA as well, which is much more common, so mini stroke, or which is often a stroke precursor, which the upcoming guidelines are going to say we need to address with a specialist 7 days a week. So we can't offer those 7-day-a-week services by specialists in either of our sites at the moment. So we can only offer what are going to be the guidelines if we join our services together. We do think that we can offer very good rehabilitation services in a number of locations, including Whitehaven, community hospitals, and indeed people's homes. And we know that after the first sort of critical 36, 48, 72 hours, it's rehabilitation services that are key. And so one of the challenges for us is going to be making sure that actually when people are ready to leave a hyperacute stroke unit, when they're outside the time window, when we know that being on that, quotes, HAZU helps, we can get them promptly back to the place that's nearest to them that can offer those rehab services. But we have to be able to provide those 7-day services for people both with TIA and hyperacute stroke.
I think there's a really interesting point there about the scale of benefit. There's sort of, and the calculations that you're having to do when you're developing these pathways that I hadn't thought of before. So I think that's really interesting, and maybe we can ask you to say that again if it hadn't quite gone into everybody, because I probably need to hear that again. But what other questions do people have? Because we're kind of getting to the point where we're last 10 minutes. So, gentleman at the back.
In March of this year, I was working in my garden, and my back clicked, and I thought I'd slipped a disc. But anyway, it turned out it's a muscle down in the bottom of my body, below the spine. I went to the doctors, could I see a physio? No, we don't have one. She's on maternity leave at the moment. So I left it at that. I went to see the local fella down the back street here, and he had a look at me, gave me some exercises to do. I was doing the exercises, he didn't improve it any, so I went back again to the doctors, and they said, well, okay, we'll get you up to C-scale. There's a lassie up there. Now, why should we have to go up to C-scale? Why couldn't they get somebody in to fill in for the person who was supposed to be down here to do it? Okay. 3 times I went up to C-scale.
Primary care services, kind of community services?
There is a physiotherapy service in Millom, based in Millom Hospital. There is. I think the question is, there wasn't when you needed it. Now I don't know the detail of this, to be honest. I'd have to look at it. But there's a number of physios who work as a team there. So I think maybe, I don't know whether the access was quick enough, or whether I don't know the details behind that. But for most routine physiotherapy services, for things like back sprains and so on, what they call musculoskeletal physio, that's available in Millom. In the room just as you come into the surgery on the right is a physiotherapy room with a. We've got some very good physios there, actually. Yeah.
All right. Another question? I think everybody's got to go at 3. So, lady's going to ask about community hospitals. We haven't kind of really talked about that because Millom's not affected by those service changes.
Consultation because it was the only one I could get to.
Yeah, absolutely. Is that all right with everyone?
Okay.
Yeah.
So I've come down from Cockermouth because I'm concerned that 2 out of 4 options involve in the community hospitals involve getting rid of Cockermouth Hospital. And my question particularly is here. It says that where beds are lost, the hospitals would have an important role within the new system of integrated care communities. Does that have anything to do with providing beds or end-of-life care or any of those rehabilitation services? That's the first part of the question. And the other is how John Howarth feels about possibly closing Cockermouth Hospital.
That's
the
a
beds,
very,
sorry, not...
very good question. I got the money for Cockermouth Hospital and worked there for 20-odd years of my career. So, first of all, how do I feel about community hospitals in general? I sit on the national committee and have done of community hospitals. I'm co-opted. I don't turn up for the meetings, but I'm co-opted, and for about the last 6 years, and been the clinical lead for the community hospitals for quite a number of years. So I care quite passionately about these units. There are a number of options. There's a lot of views from outside. If you come up from outside of Cumbria, you can't get community hospitals. Most places around the country don't have community hospitals. Most places have beds somewhere, though, in what they call the intermediate care tier. So there's the acute hospitals, and there's general practice primary care. And there's a bit in the middle and most places around the country have got some sort of bed provision within that. Now, in many parts of the country, it's done in nursing homes or other sorts of facilities. In Cumbria, but from history, it's done mainly in a network of community hospitals. The network of community hospitals have not been designed in terms of where they are. They're just history, really. So there are 5 community hospitals in Allerdale, for example. So if you come from outside, as the success regime has been a national intervention, and look, most people can't get, can we have 5 hospitals serving Allerdale? You go around everywhere, and we've been around everywhere, and we've had very detailed discussions with the places where face of losing the beds in the community hospital. Everyone's passionate about it in the community, and that's what triggered the march in the streets here 2 years ago, and 2,000 people marched in the streets because of the temporary closure for staffing of the community hospital here. The preferred option is option 1, I think, which is actually consolidation down to 3 units, which would impact on beds in Maryport, Wigton and Alston. Now, what we started to do is to sit down around the table with the protest groups in Maryport, the campaigners in Alston and Wigton, general practice, the local councillors, the local community groups, and work up to see whether we can get any better ways forward. Because if you go across to Maryport, there are 200 nursing and care home beds in Maryport. It's staggering how many there are. There's 60 or 80 extra care housing beds, and there's just a tiny number of community hospitals. So it's where we're working to see whether we can think of ways of sustaining these units, but repurposing them more to rehabilitation, or what they call reablement, which is keeping social care sort of process of keeping people beds at home, emission avoidance units. There's very interesting discussions going on. So the preferred option does not involve closing Cockermouth Hospital. there was I think a need in all of this is to set out all the things that were thought of and discussed and put them as options, including there were people who there's lots of difference of opinion on this. There's lots of people think there should be no beds in community hospitals at all, and so it's the option one does include Cockermouth Hospital. And there's even an option, one of the options is to not have a hospital in Workington, which is a relatively new facility as well, 10-year-old facility. So it's unlikely, it depends on whether, if the whole of the people of Cumbria voted for the option in that said close Cockermouth, then it might happen, but I would be very surprised if it did as a brand new purpose facility. What we need to do is use the facility. It's not used as much as we planned.
Okay.
Did that answer your question on?
I asked about so would the bed still be used if it was under the new system of integrated care communities? I just don't know what they are. Right.
Okay. Integrated care communities are essentially this. They're a way of working at a town level. So Cockermouth Integrated Care Community would be an integrated health and care team, so one team approach in the town, working in a much more enhanced way with mobilised communities, with community groups, to try and actually improve the overall health of the population. Now, within that, in some of these, there might be some beds in the intermediate care tier. There is no plan, there is an option put forward that includes the closure of Cockermouth Hospital beds, but it's not the preferred option of the success regime. So, I'd be very surprised if you build a £11 million unit and then you closed it down, several years later.
Okay. Kind of thinking about winding up now. I'm going to ask you guys in a minute just to make some kind of concluding remark, a take-home message you'd like to kind of give about what you've been talking about today, and some of the questions you've been asked. But just in terms of a plea, really. This is an opportunity to ask questions. Obviously, people have done that. But it's then down to you, really, to make your opinions known. And this isn't about everybody having a vote, but it's about you making your points within the consultation, and then the people who make the decision listening to that and making their response accordingly. And they can only do that if they get information from you. So it's a plea for you to complete the consultation in any way, shape, or form, as we've said. Sure. I think it would help Elliot greatly if you took 1 million copies off of him, because he's got quite a lot in his car. Okay. So, a concluding kind of comment from any of you? Would you like to start at either end?
Go on, John.
I think there's something special about South Copeland in this whole process, because this is the area where the pathway changes probably impact most. And you've heard very articulately from Joanne and others why you might centralise stroke services. So I think it's really important to feed in the views, well articulated, strongly held views, into this process to get the voice of the people in South Copeland heard within the overall consultation.
Rick, anything?
Yeah, I think it's really key that the comments were made around, possibly the younger element not taking note of what's going on. And I think, as people here, if you can push that to people that you know and talk to them and point them in the right direction of the consultation documents, the website, the hard copies in the library, the community, then hopefully we can get some engagement there as well and get everybody's views, which is really important.
And it's even on Facebook and WhatsApp and...
Yeah, so we did a Facebook campaign within sort of 20 kilometres of Millom. We actually had 3,000 people, and that trends to the younger demographic. So they would have seen the advert
Okay, Joanna?
I mean, I would say for all that you're concerned that the younger people in the town are not engaged, actually the people in Millom are extremely engaged in their health, and it's probably a model for the rest of Cumbria actually in terms of understanding issues, working together, working with the people providing services. So I think if we can roll some of that out to the north in terms of the level of engagement, that would be fantastic.
Last
Oh,
but not
it's
least.
always terrible when you get the last slot, isn't it? I would just agree with everything that everybody said. It's always really humbling when you come to hear people speak about their community. I live in quite a small community, but in Northumberland, and we would be equally passionate about our services. And I think what I would like to say is the people who are sitting at this table are as passionate as you are about getting the right services for patients right across Cumbria. It is a really tough ask, and the solutions or the options within this paper, we absolutely understand, are not desirable to some extent for a huge proportion of our population. I just would like people to really think about how do you get the balance of safety and how do you get the balance of risk right. And your comments are absolutely vital to us during the consultation. So thank you for your time today, is what I would say.
Great. Okay. Thank you very much for coming.